So I want to welcome everybody to the wellness webinar sponsored by the Baylor College of Medicine, the Dan Duncan Comprehensive Cancer Center, and Baylor St. Luke's Medical Center. We're going to be talking about cancer and the COVID-19 pandemic. And a lot of what we say will be appropriate not only for cancer patients, but for non-cancer patients as well. Next slide. So joining me as panelists, I'm the director of the Dan Duncan Cancer Center. We also have Dr. Mo Ramawi, who's executive medical director of the Cancer Center. Dr. Bill Fisher is director of the Elkins Pancreas Center and chief of general surgery. Helen Hislop is director for the Center for Cell and Gene Therapy. Dr. Pavan Javeri is director of the Smith Clinic Radiation Oncology. And Dr. Lisa Forbes-Sauter is a pediatrician in the Allergy and Immunology section at Texas Children's Hospital. Next slide. So our agenda is shown here. I will give a brief introduction about where we are today with the epidemic or the pandemic. And then we will talk about the impact of COVID-19 on cancer patients and their care. We have a section on COVID-19 in children with or without cancer, which is very important, obviously. And then we'll have an update on prevention and treatment, followed by questions. Next slide. So first, this is probably not needed by most of you, but what is COVID-19? Well, it's a disease caused by a coronavirus called SARS-CoV-2. You may remember SARS-CoV-1 that caused the SARS epidemic about 20 years ago. And also the MERS epidemic, more recently than that, which started in the Middle East. It stands for Severe Acute Respiratory Syndrome Coronavirus 2. It started in bats, we think, and then was transferred to pangolins and then to humans in the wet market in Wuhan, China. Coronaviruses are a large family of viruses. They cause the common cold and a variety of other more benign illnesses, but some of them are very virulent and can cause significant infections like this one we're having now. The SARS-CoV-2 virus is very infectious and can cause severe infection affecting lungs and other organs in some people. It can be transmitted from an infected person who may have no symptoms to another person. The risk of infection or severe infection varies from person to person. And the big question is, are there long-lasting effects on the lungs, the brain, the heart, or other organs? It's just too early in the pandemic to know if these affected people, even children for that matter, will have any long-ranging, lasting effects. Next slide. So the risk factors are shown here. Age is important, not so much for getting the virus, as you'll see in a minute. Young people are the ones that are getting infected. But if you have the virus and you're above 80, your chance of dying is much, much higher. Genetics must play a role because some people don't get any infection at all. Others get a very severe infection. Blood type was thought to be important. Blood type A was thought to provide a risk of worse infection, and blood type O was somewhat protective. But a recent study suggests that this may not be that important. Obesity, however, is a major risk factor, probably because obesity already stresses the lungs and the heart. Pre-existing hypertension, heart disease, lung disease, diabetes, and obviously cancer, we'll talk about that in a minute. And a recent study shows just a high fasting blood glucose, a high fasting blood sugar level, without really having diabetes itself, can also predict for a slightly worse outcome. Immunosuppression, obviously what we're talking about today, cancer and its treatment, or other forms of immunosuppression for other types of illness. Poor physical condition. Probably the most important on this slide is not following the guidelines. And there have been a number of clusters, large gatherings, churches, nursing homes, bars and restaurants, or family events, particularly over the recent holidays, that are probably responsible for a lot of the increase in the infections that we've seen. Next slide. Next slide, Mo.
Sorry, it's not responding to me. Let me see. Okay.
There we go. Okay, this slide shows the COVID-19 case increase by day, all the way up the last blue bar on the right is today. And there's good news and bad news here. You can see that we cranked along at about 200 cases. There was a little spike early on in late March. But then in April and May, we cranked along around 200 cases. And then after the Memorial Day holiday, and then particularly after July 4th, the cases really boomed and more than quadrupled in number. And now, toward the middle of July, they're starting to come down a little bit. We'll have to wait and see whether that decrease holds over a longer period of time. It's hard to say that's good news, but given what we've seen in the recent past, it's probably a good sign anyway. Next slide. So this is a slide showing the effect of age. This is on incidence, the number of cases. You can see that most of the cases are in the age range between 20 and 50. The orange colors, the pink color, the green color, and the blue color. And the number of elderly people that get the virus are small, relatively small. But if you do get it in that age group, your mortality is very, very high. So what does this tell us? It tells us that the young people are not abiding by the guidelines. They're getting infected and they're giving it to older people who then have a very bad course. Next slide. So what about Harris County and Houston? Here's the confirmed cases by zip code. You can, if you wanted to, you could look on the Houston public health website under COVID-19, and you can find out what actually the incidence of the virus is in your particular zip code. And they're shown, some of them are on the right. You can see the big differences. Some are very low, some are very high. But you can also see in the map to the left that it's all over the city, really. There's not a place really that's spared having an infection. Next slide. So what about our own hospital system, the Baylor St. Luke's CHI system? This shows the Texas Division Hospital. These are inpatients in the 17 hospitals, including Baylor St. Luke's Medical Center, in the CHI system. And the curve starts back on March the 1st and goes all the way through yesterday. This is very recent data. The blue are those cases that we know are positive because they've been tested. The orange are cases that were not tested or are waiting to have the test. The light blue, you can see the very light blue on the right-hand side of the slide, right there, thanks, Mo. Those are cases waiting for a bed in the emergency room because there's no beds. So you can see the problem that we have. The hospitals are becoming saturated and the ICU beds are full and there's just no place to put these people. Of course, that raises a problem for someone who doesn't have COVID but has a significant illness and needs to be hospitalized. Where are they going to go? Next slide. This is Baylor St. Luke's Medical Center Hospital, the positive rate and the probable positive trend shown in orange. And you can again see the light blue with patients waiting in the emergency room. The good news is it seemed to have peaked shortly after July 4th and seems to be coming down a little bit now. We'll have to wait and see whether that trend continues. We hope it does. Next slide. What about screening for early detection of cancer? That's an important issue because a lot of people are staying at home. They're afraid to go to the hospital to have their screening test done. But the hospital or clinic, we've now shown, is a relatively safe place to go if you are sick or for cancer screening, for a mammogram, for instance, or colonoscopy, or your GYN exam, or other exams needed for cancer screening. So you should not delay your screening. In fact, a recent publication suggests that there will be 10,000 more deaths from breast and colon cancer, just those two cancers, in future years due to delayed screening. So if you have a significant health problem, go to the emergency room or to your doctor. Also noted there's fewer heart attacks now seen in the ER. People with a heart attack and chest pain are afraid to go to the emergency room for fear that they're going to get the virus. And then they're delaying a really important reason for going to the hospital and actually having a heart attack. Next slide. Dr. Ramawi is going to go over this study about cancer screening. You're muted, Mo.
Sorry. Thank you, Dr. Osborne. So this, the next two slides are going to show us the impact of COVID-19 on cancer screening. This is data pulled from the Electronic Health Record Network that pulls diagnoses, of course, without identifying information for multiple medical records. And the line that you have here, these two pink lines are essentially 2017, 18, and 19. There are three of them that are all overlapping. This is the one in the middle is colon cancer screening, and then the one below is in green is cervical cancer. And you could see that we diagnose, throughout the months of the year, January, February, March, and so on, we diagnose about 10,000 cases a month of breast cancer, about 3,000 cases of colon cancer, for example, and about 1,200 cases in the U.S. a month. Here's what, in the dark pink, the dark purple, and a little bit darker green, you see the dip that happened in March when we started seeing more COVID-19 cases. And of course, it's not that cancers are not happening, we're just not diagnosing them. So when there was a shutdown of health systems, we actually, patients stopped seeking care, and we stopped diagnosing them. And that's a profound drop. This is only 5% of the monthly diagnosed rates of breast cancer, same about 10% for colon cancer, and about another 5% for cervical cancer that were diagnosed, which means there were thousands upon thousands of cases that were not diagnosed. And this is where Dr. Osborne was talking about the expected unfortunate mortality that's going to result. Now, a little bit of good news is that as the health systems continued, recovered, they got the PPE, they opened up, cases dropped, we actually kind of started picking up those diagnoses. As you could tell, the line is going back up to baseline. Now, of course, there's still multiple cases, multiple screens, about 285,000 estimated screening in breast cancer that were missed, about 95,000 screenings for colon cancer, and 40,000 screening for cervical cancer. So these are cancers that we've missed. We haven't yet made up the difference. The danger here is that if we, of course, get another surge in COVID, or the surge doesn't come down, this line of diagnosis could fall back down again. Dr. Osborne?
Thank you. Well, let's now turn, after that introduction, to more pertinent information regarding cancer patients. And these are some of the questions I'm going to ask our panelists to answer. One of them is, are cancer patients at higher risk? Who is or who is not? What precautions should patients take who are on chemotherapy? Does radiation therapy increase the risk of infection? Should radiation therapy be delayed in some patients? What about surgery, elective surgery? We've heard a lot about elective surgery being postponed. Emergency surgery or cancer surgery. Is surgery being delayed because of lack of capacity in the hospital? And then what if I need hospitalization for something else? So let's address the first question. Maybe Mo or Dr. Ramawi or Dr. Heslop can answer this question about our cancer patients at a higher risk.
Dr. Heslop, would you like to comment?
I'll start with, I think some cancer patients are. It depends on how suppressed their immune system is and where they are in their cancer treatment. So I treat patients with blood cancer who are having bone marrow transplants, and those patients in the early post-transplant stage do have a weak immune system, and they're at risk of lots of different infections. So these are people who have worn masks and done physical distancing before we all started doing it. So I think those patients do have an increased risk. As they get further out of transplant, I think their risk goes down to it's the same as normal people. But I think they've probably got the highest risk. And then with other cancers, it varies with different solid cancers. And as Mo's a solid tumor oncologist, I'm going to hat this one back to him.
Yeah, thank you. So with regards to solid tumors, I think it depends on the type of tumor, depends on the treatment the patient on, and what phase of their battle against cancer they're in. So, you know, a patient who's getting active chemotherapy for breast cancer, for colon cancer, you know, for lung cancer may be at an increased risk for COVID-19 because the chemotherapy could compromise their immune system, and those patients certainly need to be extra cautious and follow the guidelines of masks and hand hygiene and physical distancing very strictly. There are, of course, patients with cancer who may be on targeted therapy, maybe on even in active surveillance, meaning that they're just taking some maintenance therapy like hormonal therapy or other biologic, or just being monitored closely by their doctors. And those patients may be, you know, at a standard risk for COVID-19. But of course, that doesn't mean that they shouldn't be careful because there are long-term sequelae for the cancer treatment, the surgery, the radiation, the chemotherapy that the body may take a long time to recover from. And so I would say across the board, caution is necessary. Some people have a higher risk than others. And of course, you always have to consult with your physician to see what is your individual risk and follow the guidelines quite strictly so as not to compromise your outcomes. The other thing is that sometimes the COVID-19 patient, a cancer patient, if they get COVID-19, could actually delay their cancer care. So that's also another thing we wouldn't want to happen, and this is why we advise caution generally.
So, Dr. Ramai, a common scenario is a breast cancer patient who may be 5 or 7 years after their original diagnosis and treatment, and they're just on tamoxifen, or they're just on an aromatase inhibitor, a pill. What about those patients? Are they at increased risk?
So these patients are not considered generally at an increased risk for COVID-19 because the treatment that they're on is not compromising their immune system in any meaningful way. Hormonal therapy for breast cancer being one. There are also some targeted treatments that people take for other tumors. And of course, there are the patients who are on just active surveillance. Generally, we recommend always for the patients to continue to be on their cancer treatment. We've received multiple queries from patients wanting to stop their medicine. I think that unless directed by their physicians, cancer patients should continue to take their treatment. But the example you gave, Dr. Osborne, is not a particularly increased risk than the general population.
Great. What about when they're actually on chemotherapy? Do they need to do anything in particular other than just being extra cautious with the usual things?
I think from my perspective, of course, patients need to be cautious all the time, not compromise on it, not have anyone without a mask come visit them. If they go outside and go to somewhere where people are not wearing masks, they shouldn't go in, like a grocery store or anywhere else. So I think, they should be very cautious around that. Now, the other thing about patients who have, are on active treatment or active chemotherapy is that they could develop symptoms related or that may be interpreted as COVID-19 that could be other infection. So, fever, we always caution the patients to call us with fevers, chills, cough, chest pain, or other symptoms. And these could be COVID-19, this could be a different virus, this could be a bacterial infection, all of whom, have maybe serious on a cancer patient. So if a cancer patient feels any of these symptoms, they should have a very low threshold of calling their physician immediately, day or night. None of us minds, and let us know so we can direct them the best way how to take care of it.
Thank you. Dr. Javier, you want to talk about radiation therapy? I think you have some slides to show.
Yeah, I do. Share my screen. Okay, you guys can see this okay?
Yeah.
So, yeah, I mean, one of the most common questions that I get is, the impact of radiation therapy on a patient's immune system. So, before I begin, there's a big caveat and grain of salt with all of this, and just like you guys have already touched on, it's very individualized, and it really depends on each particular patient's case. But in general, radiation therapy does not affect a patient's immune system It's not a whole body treatment. It's usually targeted to a very specific area that we have the ability to treat while avoiding dose to structures and normal organs that play a role in the immune system. There are, of course, exceptions to this. In general, when you combine chemotherapy and radiation therapy together, you can have a effect on the immune system both together. Another important category of patients is when we treat in the pelvis. We often have to treat a large portion of the bone marrow in the pelvic bones, and that can have an effect on the immune system. Each radiation therapy plan is very unique to a particular patient and unique to their case. And so really it's a discussion that you're going to have with your radiation oncologist, your medical oncologist, to determine the exact effect on the immune system.
Could I ask you about patients with Hodgkin's disease and lymphoma? And because they often get fairly large amounts of radiation in different parts of the body, and maybe they're already a little bit more susceptible to infection.
Exactly. So in the case of Hodgkin's lymphoma or non-Hodgkin's lymphoma, if they're getting chemotherapy up front, we often have to treat, depending on their situation. As the science has moved forward, we're able, and as the chemotherapy has gotten better, we've actually been able to reduce our radiation fields and reduce our targets. So we're able to avoid that. But yes, that's one particular instance where there is an increased risk of having an effect on the immune system. There was a question I saw prior to that was submitted from the audience. When does the immune system come back if it's affected by radiation therapy? In general, we expect the immune system to come back within 2 to 4 weeks. That's assuming that they're not having any other treatments or any other effect on the immune system.
Thank you.
I think your next question is, should we delay radiation therapy, or when should we delay radiation therapy? It's a very good question, another very common one that we talk about with each patient. In general, when we recommend radiation therapy, it's for a very specific reason in that particular patient's treatment course. So there is a percentage of patients that actually we can safely delay. Usually these are instances where you have other treatments that can provide cancer control, and we can give the radiation therapy at a later time point, and it doesn't affect their outcome, and it's not a detriment. In a lot of situations, for a lot of patients, we can't safely say that it's okay to delay. And this is very individualized, and once again, a conversation with your physician. So when we do recommend having radiation therapy done, it brings up a question as to how do we deliver this safely, right? This is a very kind of important thing within radiation therapy, because as some of you know, when you deliver radiation therapy, it's not a one-time thing. It's generally over 5 days a week, over multiple weeks, and you have to come into the clinic. And so how do we make those daily treatments as safe as possible? And this is one thing that has become kind of very important while we've been dealing with this pandemic, is how do we continue a necessary treatment and a safe treatment? And I think it applies to all of us. In radiation therapy, because of the daily visits, there's a couple steps that we do for each patient to ensure that they're properly taken care of. One is determining the urgency of treatment. So as we talked about already, if we can delay appropriately, then we will delay. The use of telemedicine and video visits to reduce the traffic into the clinic. While you're getting radiation therapy, there's a very aggressive proactive care approach in terms of ensuring that we do everything we can as a team to keep patients out of the hospital, to reduce the burden on the hospital and to reduce exposure. Within the clinic itself, waiting room limits, screening for all visitors. I think we're all familiar with this, phone call check-ins, specifically for the radiation therapy machines and the linear accelerators and the treatment rooms. We have COVID-specific daily cleaning protocols that have been developed. Staff care is very important, right? So all faculty and staff in masks and face shields and other protective measures. And then importantly, collaboration, right, is very important for all of us. Within the Cancer Center, figuring out best practices. As we get new information and new data about COVID-19, about its effect on patients, what are the best things that we can do to ensure that we're kind of at the forefront of taking care of our patients. And then that collaboration also extends to other major institutions and conversations to see what they're doing and have an exchange of ideas to ensure that we're really at the edge of this, taking care of this for our patients, right? And the idea is that we still provide that high level of care, but we do it in a very safe manner to continue to take care of our patients.
Let's go back to Dr. Ramai's screen. Okay, Dr. Fisher, what about surgery? Both elective surgery, we've heard a lot about that, emergency surgery, cancer surgery. What's the deal there?
Are you able to hear me okay?
Yes.
Great. So yeah, I can give you some, some inside information really that you may not get on the news about what's going on. So in the hospital, it's very important to understand that we have a mission. Our mission includes taking care of the COVID-19 patients and serving the community. But part of our mission is also to take care of all the other diseases, including cancer and many other things that we take care of. And so we have to have a balance of the resources. So a great number of things have been done to assure patient safety and to maximize the amount of good that we can do. So every morning there's a meeting that I've attended for months now, and we look over a dashboard of what the resources are. And this includes PPE, which is personal protective equipment. This is the gowns, the gloves, the masks, and things like that. The dashboard also includes a number of beds, so regular beds, ICU beds, the availability, and it also looks at staff, which is important because if our staff are out sick with COVID, then we don't have enough staff to take care of the patients. So on a daily basis, we're assessing that and determining, how many surgeries can go forward and what we can do. So a little bit of that depends on the nature of the surgery. If it's a big surgery that's going to require the ICU or a ventilator, that's going to be one thing. If it's a more straightforward surgery, that's something else. So right now, we are still doing, we haven't canceled big cases very much at all. Some of the heart cases maybe when we're running low on ICU beds or ECMO. But most of the cases are going forward, including elective cases. So elective cases that don't require an inpatient stay. In other words, the patient comes, has surgery, goes home the same day. So an example of that would be maybe having a port placed for chemotherapy access. Those things are still ongoing. And a number of things are being done in the hospital to assure the patient's safety. So every morning when we walk in, we get asked about symptoms of travel. Our temperature is taken, and everyone in the hospital, every doctor, every nurse, every person in the building is wearing a mask. And now in the last 2 weeks, we've begun wearing face shields as well. Of course, social distancing. Some of this is a little hard for the patients, having surgery. Our visitor policy is pretty restrictive, but that's for the family's safety as well as the patients. And I think everybody understands the need for that. And all the usual things we always do, hand hygiene and things like that. So we're also testing. So all of the people that work in the operating room are getting tested when they're asymptomatic, up to once every 2 weeks. And of course, anyone with symptoms doesn't come in and gets tested right away. We're also testing all of the patients. So anyone coming in for surgery is also being tested for COVID before they come in. it's important for patients to understand that we have designated areas in the hospital for patients that have COVID. So there are, particular intensive care units where those patients in floors of the hospital where those patients are clustered, and we, to every extent possible, keep the patients separated as well as the people taking care of them. So I think the message is that it is very safe, and that you shouldn't delay surgery. If you need surgery for cancer, you need to go forward with that, because of course a delay can lead to a progression of the disease, and make it turn into a situation where surgery might not be possible. We've done many of those same safety precautions in the cancer center. So if you're having symptoms and need to be evaluated, need to come in, all those things that I talked about that the staff are doing to maintain safety are also being done in the cancer center clinic as well.
Thank you. Next slide, please. What about children? Maybe Dr. Satter can talk to us about them. A lot of issues there.
Thank you so much. I'm going to go ahead and share my screen. So, okay, so what about children? There's a lot of talk in this pandemic that children aren't as affected. And I think that the smaller percentage of children are actually affected by the pandemic, but they still can have some complications. So children can absolutely get COVID, and children with cancer can absolutely get COVID as well. About 5 to 6% of the reported cases in the United States are under 17 years of age. And most patients under 18 have mild symptoms and fully recover. And they usually recover quicker than adults do. And yes, kids with cancer can get the virus as well. And I'd like to highlight what Dr. Heslop said, is that what kind of cancer, where in your treatment, and the kind of immune suppression therapy that patients are receiving really play into which patients are most at risk for severe complications. So at Texas Children's Hospital, we have tested a little over 29,000 patients since the pandemic started, and a little over 2,000 patients have become positive. We've hospitalized, as of yesterday, about 400 patients since March, and the majority of them have been greater than 2 years of age. The two major age groups are less than 8 months, but most of them are over 2 years of age. We've also started to admit some adult patients into our COVID units. So we've had a few patients in their 40s and 50s admitted to Texas Children's Hospital for care, but the majority of patients are under 27 years of age. And thus far, we have had 41 cancer patients in the Cancer Center positive, with 40 hospitalizations, many of those for observation. We have them in our COVID isolation units, as well as where they're being treated for their cancers on the oncology floors. One of the major complications in children is something called multisystem inflammatory syndrome in children, or MISC. It was first reported in late April in the United Kingdom as being a post-infectious inflammation response by the immune system that causes a constellation of symptoms, including fever, gastrointestinal, mucocutaneous, meaning in the mouth, and in the gastrointestinal tract, a lot of inflammation. Some patients have cardiac signs and symptoms, and they all, for the most part, have significant elevated inflammatory markers. It has some overlap with something called Kawasaki disease, which is an inflammatory complication in children that can affect the heart, the skin, the eyes, or toxic shock syndrome, which is closely related to an inflammatory syndrome associated with staph infections. In May, the CDC actually put out a health advisory and defined what MIS-C was and how to treat it. The majority of kids that develop this inflammatory complication develop it within 2 to 4 weeks after having mild symptoms or being exposed to the virus. And mainly the age groups are 5 to 14 years of age, with a few patients in their late teens and early 20s. Right now, Texas Children's has treated about 16 patients with MIS-C, and the age range is from 3 to 20. And this is since about late April, beginning of May. So school or no school is the question. There's a lot of guidelines out there as to how we should re-enter our school year. The CDC, the American Academy of Pediatrics, UNICEF, the American Federation of Teachers, and some states have come out with some pretty specific guidelines on how they feel certain schools should open. Texas has left it to district by district as to how the particular school district is affected. And the CDC guidelines recommend that the schools implement their policies based on the degree of community spread. And of course, Houston is actually in one of the more severe categories. So can children carry the virus and spread it? And absolutely they can. So although that only about 5 to 6% of patients in the US are children, one of the major concerns when there's severe community spread is that children can actually spread it to their family members, their more at-risk family members, older family members, and family members whose immune system is suppressed. So there has to be a really good focus on strong communication strategy within the community and within the schools. And there's a few things that all of the guidelines across the US make sure are present. Sanitation and hygiene within the school policies, symptom surveillance of staff and children, quarantine and school absent policies for symptomatic and exposed persons, masking, ventilation system assessment, physical distancing, and cohorting. Cohorting means having smaller sets of children go to school in varying degrees, in varying days. So keeping the classroom sizes smaller and alternating days. There has to be flexible attendance policies for students, teachers, and staff, adjustment of school calendars for severe community spread within certain districts, increased capacity of school health services to accommodate the increase in exposed persons as well as symptomatic persons, and the maintenance of immunization schedules, especially the flu vaccine, because the school year, as we enter the school year, we enter flu season, which can also complicate our patients' health and viral spread in the community. We have to have increased transportation options for our families and flexing with sports and music programming and recreational activities dependent on community spread. One of the major things that we are actually recommending to our patients and our families is to understand what the school districts are doing in your area and then have a thoughtful conversation about the strategies the school district has put forth and what's best for the family and what's best for the patient themselves. And a lot of options that the school districts offer for accommodations should be taken advantage of during these times so that teachers at risk, students at risk, and students' family members at risk are well protected during the severe community spreads that we're experiencing here in Houston.
Thank you, Dr. Satter. All right, prevention and treatment, what works and what does not. Masks, Helen, do you want to talk about the mask? You have an interesting slide that describes aerosols versus droplets.
Yes, I can show that. So this is actually a a nice slide that was in an article by the infectious disease people in San Diego in Science. And it shows here you've got a person who's infected but asymptomatic, so doesn't know that she's spreading. And you can see here she's spreading to somebody in a mask who will have a little bit of protection, and then also to somebody without a mask who's going to have the maximum exposure. But if she now wears a mask, you can see there's much less transmission of droplets. So the person here wearing a mask has very good protection, and even this person without a mask has much better protection. So even if she does get infected, it's probably going to be with a lower dose of virus, and that has an association with a less severe infection. So masks, I think, are very important. They've been shown in multiple studies that they can prevent infection. So I totally agree that everyone should wear them until we've got a vaccine.
Thank you.
Do you want me to move on to talk about vaccines or later, Kent?
We'll just talk about some other stuff just briefly here.
Okay.
Obviously, social distancing, the mask you talked about, avoiding crowds. What about inside versus outside? Mo, you want to talk about that just briefly? Outside?
Yeah, I mean, outside is generally considered safer than inside. You know, inside there's, you know, more restricted airflow, less ventilation, and so these droplets are more likely to get from one person to another. And just generally speaking, you know, usually an indoor space is going to be smaller than an outdoor space. Outdoors, you know, it's there's more ventilation. People could distance more optimally, and so there's less spread of droplets.
Thank you. We've heard a lot about some of the drugs that are being used to treat COVID-19 patients. Dr. Ramali or Dr. Heslop or Dr. Satter, do you want to talk about those?
I think I've got a slide that shows the different stages, so maybe I can do that, then everyone else can chime in. So if you think of COVID sort of simplistically, there are probably two stages. The first stage is where the virus has infected you and it's replicating. A lot of people don't have symptoms during that stage. Some will just have very mild symptoms and will stay home and recover with supportive care. But if patients have moderate symptoms and they come to hospital, there's an antiviral drug called remdesivir that has been shown to have benefit. So patients who are in hospital may get remdesivir, which is now approved under emergency use. They may be offered other experimental antiviral drugs on clinical trials. There's a lot of them out there at present. Another option is convalescent plasma from somebody who's recovered, where there are going to be antibodies that should neutralize the virus. And there are also monoclonal antibodies available in trials now that neutralize the virus. So all these therapies in this stage are targeting the virus. Some patients, after about a week to 10 days, develop a second stage where most of their symptoms are now due to inflammation and a dysregulated immune response. And this is the stage where a study in Britain showed that a very common steroid called dexamethasone could have benefit. And that's because this very broadly dampens down the immune system, affecting lots of different cells. People have also looked at anti-cytokine antibodies here that we use to treat a similar sort of inflammation in patients who get CAR T cells. The single antibodies don't seem to work so well, but maybe the combination can be beneficial. And people are looking at a lot of other drugs and cells that dampen the immune system in these patients. These are also the patients who might have anticoagulation because the inflammation can increase their risk of clotting. So these patients in hospital routinely get anticoagulation now. I don't know if Lisa or Mo have anything to add to this section on therapies.
I just have one thing to add. For the children who develop the inflammatory complication after having mild disease, the MIS-C syndrome, we also use steroids like dexamethasone and intravenous immunoglobulin as well to modulate the inflammation, especially if they develop any kind of cardiac or heart complications. In children, we are adding dexamethasone to a lot of our patients that have been admitted and we have been using the anti-cytokine anakinra as well for the inflammation. So we just activated our clinical trial for remdesivir and do have it for emergency use as well. So a lot of the things that are available for adults are also available for children.
Children, yeah.
We've heard that the mortality from COVID has come down a little bit, probably as we've learned more about it, how to position the patient, some of these medications. But also the patients that are getting admitted now are younger, and they have a better survival anyway. So Mo, did you want to say something?
No, I was just going to refer to proning, positioning, which you alluded to, Dr. Osborne, which, the majority of our lungs are actually in our back, and we usually lay patients on their backs when we want to ventilate them. And there's just a simple technique of putting them actually, on their bellies, if you will, kind of frees up that space, and it makes for more optimal ventilation. They are less likely to require intubation and more likely to recover from it if they get intubated. And it's a simple positioning that actually made a big difference in ICU care for these patients.
Yeah, and I think the ICU physicians have also learned a lot about the way of delivering oxygen. Initially, they were intubating early, but now they're using lots of different high flow mechanisms, so many more patients avoid having to have mechanical ventilation.
Yes.
Well, before we turn to questions, let's talk a little bit about vaccines, which are probably the most talked about issue right now. Dr. Heslop, you've done some work in this area. Why don't you go ahead and take over?
Yeah, so what happens in a person who gets COVID and recovers is that the virus is processed in their body by special cells called antigen-presenting cells, and then immune system cells called T and B cells end up fighting the virus. And it's important to really fight it in two ways. The B cells make antibodies that then neutralize the virus and prevent it from infecting new cells. And very specialized immune system cells called T cells recognize proteins on the virus and destroy infected cells. So you hear a lot about antibodies, but because I work on T cells, I'm also biased, and I think they're very important. So what all the vaccines are trying to do is to try and produce these good immune cells without getting the illness. And there are lots of different types of vaccine. There is the classic vaccine, which is a weakened virus, where scientists change the virus so that some of the proteins that the immune system sees are there, but it doesn't give you a severe infection. And that's one sort of vaccine. There's a lot of groups, including Peter Hotez at Baylor, working on protein vaccines, where you take little bits of protein from the spike protein, which is on the surface of the virus, and then make an immune response against those. But there are some newer vaccines too, some where a little bit of the coronavirus is put in another virus, like a common cold virus. And when you're immunized with that, you don't get COVID, but hopefully you make an immune response against the COVID proteins. And there are some where you just put a little bit of the COVID spike protein into some other DNA or RNA and then inject that to make an immune response. So these are just a list of some of the vaccines that you may have heard about. Some of them have reported some early stage studies. There are all sorts of different vaccines made by a lot of companies. There have been about 3 phase 1 trials reported that you've probably heard about in the news over the last week. And they're very encouraging in that there haven't been any severe side effects. They have induced antibodies in all the studies and T cells in 2 of them. So I think that's encouraging. It's not a complete promise that inducing the immune response will protect you from COVID, but we hope it's going to correlate. So some of them have very ambitious goals for when they might get emergency use authorization from the FDA. I hope these companies are right with fall 2020, but I think it might be a little bit ambitious. But a lot of them think that by next year, there's a good chance that they'll have a vaccine. And as Dr. Fauci agrees with them, I'm hoping this is accurate and we will have this option soon. But until then, I think everyone keep on wearing your masks.
Thank you. Oh, can you put your slides up again? While we're doing that, next slide. we can turn to questions. And I've got several here that people sent in before the webinar tonight. One of them is, are there any diet changes that a cancer survivor should make to protect them? And I think the answer to that is no. Just a healthy diet, trying to lose some weight, because obesity is a risk factor, diabetes is a risk factor. So I think that would be the most, the best recommendation would be a good healthy diet.
I'm going to ask Dr. Ramawi about vitamin D.
So of course, that vitamin D is important for the health, bone health. It's important for breast health, and it's important for respiratory and immune health. And generally speaking, because our message to avoid direct exposure to the sun and using sunblock or sunscreen is effective. A lot of people are deficient in vitamin D, so it is recommended to actually take vitamin D supplements for everyone, particularly women. And those who don't get sun exposure. It helps bone health, breast health, general health, and it may help respiratory and immune health. It doesn't hurt to do it.
This was touched on a little bit, but should survivors be getting a flu shot? I think I can answer that. Yes, everybody should get a flu shot.
Absolutely.
Because if you don't have one and you get the flu, people are going to think you have COVID-19 when you don't, and it's going to confuse the situation. And if you got both, flu and COVID-19, then you're in real trouble. Yeah. Everybody should get
more important than ever this year to get a flu shot, I think.
Yes, absolutely.
All right. We talked about cancer survivors already. All right. After chemotherapy, is one's system still considered compromised? I think we dealt with that. Is there anything extra one should do during this time? Just be extra cautious while you're on the chemotherapy and for a little while after you're finished with it. Radiation we talked about. Okay, is it true that type A blood type, we talked about that. Are there any recommendations to shorten the cycle of COVID other than to treat the symptoms? I think we talked a little bit about remdesivir, which does shorten hospital stays, and dexamethasone. Anything else there that you might want to recommend to shorten the cycle of COVID?
I think it'll be interesting to see the results of the antibody clinical trials, but they're just starting in trials at the moment, so we don't have the information. But it would be nice if we did have a therapy until the vaccine's ready.
Here's an interesting question, which is really important, I think. Cancer patients or survivors who work in a school, who are teachers, is it safe to go back, and how can they protect themselves? This is a real issue because we're not so worried. Maybe Lisa might disagree with me. We're not so worried about the kids getting infected because they usually do pretty well. But we're worried about the kids giving the virus to somebody else, either their parents, their grandparents, or their teachers. So what can teachers do?
I agree with you. I think for the most part, kids are having mild disease. And of course, the ones we see in the hospital are the more extreme cases. But I think that teachers have to protect themselves. And for those who are shortly after chemotherapy, I think that working with your district for the option of teaching remote learning, wearing masks and social distancing, and making sure that strategies for hygiene and cohorting and all of the things that we talked about are in place for the teachers at risk. The children are more at risk of spreading it, like Dr. Osborne said, to adults that are more at risk than their classmates.
Should airplane travel be completely avoided? Who wants to take that one on? I can tell you, I haven't been on an airplane.
Well,
I think I did 200,000 miles last year, and I've done no travel since February this year.
Yeah. I think travel should be limited to what it's necessary. Until we have a vaccine, I think people should avoid travel that's not needed.
Okay. Other questions? Do we have any? Who's going to read it?
I think there was one that Bill Fisher already answered about getting a test.
I saw a question on here on how soon should cancer patients or survivors get the vaccine once they're available?
So, I think I would say that as soon as possible, but of course, in coordination with their physicians, Dr. Heslop can comment on the timing for leukemia patients and transplant patients. But generally, I think the cancer doctors would want them vaccinated.
Yeah, transplant patients, when they can't make an immune response, would have to wait till they can. It would be important to have family members vaccinated. So someone's asking, would we all be volunteers for some of the virus trials? I presume she means the vaccine studies. I think so, yes.
I would be.
Yes.
Um,
And I think the treatment trials, it would be like any trial. You look at an individual trial and decide what the benefit and risk was when your doctor explained it to you. But I think I would certainly, I think if I had it, want to try the antibody trials if I was eligible.
Here's a question, Dr. O'Malley, from one of your patients. She has immunoglobulin G deficiency diagnosed by her allergist. Does that make her at higher risk?
I would consult my friend Lisa on that.
That's really interesting. Our patients with antibody deficiencies are faring very well. I would consider that if your allergist has recommended that you have immunoglobulin G replacement, that you stay, adherent to that. If you're not quite there, be very, very careful with your mitigation strategies. We're not quite sure why some of the antibody deficient patients have actually been okay when they have gotten it. But I think that the other risk factors related to antibody deficiency are important to remember. So lung infections, sinus infections, and the things that make patients more at risk for severe complications with COVID. So my recommendation is adhere to the therapies that your allergist has given you, and be very careful with your mitigation strategies. So masks, social distancing, good hand washing, and minimizing your interactions in your bubble. So make sure all of the people in your life are doing the same things with their strategies to stay safe.
Thank you.
When out for doctor visits and grocery shopping, should we need to change our clothes when we get back home?
I don't think there's a lot of great evidence that the virus stays on clothes for as long. I don't know that we have a clear answer for that. I would say that for anybody that feels that after coming home, washing their hands and changing their clothes makes them feel that they have done their best to keep themselves safe, I think it's not an unwise practice, but we don't have a lot of good studies that point to the fact that it stays on clothes.
Okay. Is there any other way to
Yeah.
boost your immune system?
I would say exercise, a really good diet.
Sleep well.
Sleep well, yes, absolutely.
Well.
And just self-care. If you can, things like meditation, yoga, and good exercise along with good sleep and diet have been shown to keep people well. So keep with those strategies for sure.
There was a question related to diet about, is it true that people should avoid cold drinks and just opt for warm drinks? And I haven't seen any evidence that that actually makes any difference for common cold or COVID.
Just on the chat.
That I thought it's it's important for people to, as you pointed out, eat healthy. Another thing we noticed, we're not going much outside, much out of the home. So you could exercise, increase your exercise, and tweak the cooking to healthy cooking, and that should actually help with a healthy living.
When will flu shots be available this year? Do we know? And when would be the best time to get the flu shot?
Usually they're available towards the end of September and beginning of October. And I would say that as soon as they're available, I would make an appointment with your physician or to have one, or see if your local Minute Clinic or Walgreens, if that's easier for you, but make sure that you get it.
Here's an interesting question. If you go to schools, is there an advantage of having the students stay in one classroom the entire day and have the teachers change rooms if they require multiple teachers? What do you say about that, Lisa?
I think that that's one of the cohorting strategies that some districts have considered. With the proper distancing in the classroom, especially for the teacher, it minimizes the amount of people in the hallways and the opportunity to spread. And so I think that is one of the important strategies that secondary education schools like high school might be employing.
Some of these, I think, strategies in schools are going to be really difficult to implement in large public schools. In private schools, I think in the UK, they started doing this as well.
Mm-hmm.
They have students in pods, so-called pods, of maybe 6 or 8 students. And those students stay together all the time. They don't mix with the other students. They have playground time together, etc. And they only have one teacher with those students, such that if one does get infected, they're not going to infect the entire school. They're only going to infect potentially the other children in the pod. Is that a decent strategy, do you think, Lisa? If you can do it.
If you can do it. I think that the strategies that, for example, the HISD and Fort Bend County Independent School District have implemented. So for example, the Houston Independent School District is having virtual for the first 4 to 6 weeks. I believe it's 6 weeks. And then they're reassessing what the community spread and what options for strategies to keep people safe in the schools once they do reopen. Whereas Fort Bend ISD opted for as much of a virtual year as possible because of the rate of community spread and the concern for putting their own district at risk. And so I think that one of the important things to remember is that schools are still going to be offering services to the meal programs for families. Schools are still going to be offering are an important place for childcare for parents that have to work and don't have resources. And so I think that for the combination of virtual and in-person, and majority moving to virtual, you'll be able to do those cohorting strategies for children who don't have another option. So I think that there's going to have to be good communication and good strategy moving forward. But unfortunately, I do think that starting in a virtual way in the very beginning of the school year, given the density of community spread that we have right now, is probably the safest thing for our schools if possible.
What about using, and this is a question, I'm not sure I understand it, non-anticoagulating heparin in COVID-19 patients? Maybe they just mean to anticoagulate your blood with heparin, which is something that's being done. I don't know if heparin's being used, but other anticoagulants are being used in some patients.
Heparin.
Yeah, I mean, they're being used in prophylactic doses. So I think this is what they
right.
What they meant.
Low doses.
Yeah, and which is what's being done right now.
Yes, there's a lot of recommendations from the American Society of Hematology and other societies on how to best do this.
One of the issues of this whole COVID epidemic is patients who die are without their families. And it's a terrible situation. You can't have a funeral often. And the patient may die all by themselves, except for nurses and so forth in the hospital. The same thing is true for surgery in some ways, in that what is scary about surgery, even elective procedures, is not having the family with you. Is Baylor doing anything to support patients in this effort? I don't know if Bill Fisher's still on the line or not.
Yeah, I'm still here. So, yeah, we certainly are. And the visitation policy is something that we're addressing on a daily basis as well. And, you know, as soon as we're able to relax that safely, we will. For example, at one point we weren't allowing anyone in at all, and then we changed to allowing one caregiver come in the morning of surgery, and having one caregiver come in the day of discharge, and that's what we're doing now. But as soon as it's safe, we would relax that, because it is very stressful for someone to come in, and for their family to come in for particularly a big surgery and not have their family members around. We do as much as we can to mitigate that. We, of course, when we finish the surgery, the surgeon is calling the family and communicating in lieu of going out to the waiting room and talking to them. And when we make rounds, we typically will get the family on the phone as well, so that we're communicating. But it is a tough thing. But we have to do this for safety.
Yeah. All right, let's see. Will there be enough flu vaccines for all this fall? I think so. I don't think that's going to be an issue. Although I guess it has been in some recent years. Hopefully it won't be this year. Where does Baylor stand in regard to their vaccine development, Helen?
Well, I know that Peter Hotez is one of the people who's developing a peptide vaccine, and I think they're pretty close to clinical trials as far as I understand it.
Yep. Your group has also had done some really interesting work treating other viruses that affect patients who undergo bone marrow transplant. Are you trying to look at that particular technique, that is adopting or educating T cells to attack this virus?
Yes, Anne Lean's done quite a bit of work on that. She's looked at the immune response in patients who've had COVID. And actually, interestingly, about half of normal donors who happen to have COVID have a pre-existing immune response, probably because they've had other coronaviruses. So one question is, are those people going to be the population that have a mild case of COVID because they have a pre-existing immune response? That's still an open question, I think. But she is looking at making T cells from donors who've recovered from COVID to give to patients who've got COVID. The challenge here is going to be that you want to give it when they've got a severe viral infection and you think they'll need the extra help, but you don't want to give it to the patients who've got the inflammatory response. So it's just going through the stages at present of how do we design the clinical trial best to achieve that.
Thank you. Here's a question about prostate cancer. Given the hormonal implications of testosterone or anti-testosterone therapy in prostate cancer and its implications for hypercoagulability, is there any special COVID consideration for prostate cancer patients? I would guess I could probably answer that. Some prostate cancer patients are at a higher risk for thrombosis. And so I think that if they develop COVID-19, probably anticoagulation would be the most appropriate for them because of their increased risk of developing blood clots. Anybody else have any other answers for that? Okay. My spleen was removed during pancreatic surgery. Am I at greater risk for COVID?
I think Bill Fisher's got a nice answer already written there.
Yeah, so appreciate the immunologist input here too, but it's mostly for what we call encapsulated bacteria, like the pneumonia bacteria that we worry about and vaccinate against after splenectomy. And that, of course, should be repeated every 5 years, so you're up to date, just like with your tetanus vaccine and other things. But the risk of getting COVID, to my knowledge, is not greater for someone who's had a splenectomy.
Would you send your child to a private school that is refusing to offer a remote tuition choice with a school start date of August 13th?
No, I think that one of the things we're telling our families is to work with their provider, their physician, to help craft the patient-specific needs for the family and the students' risk factors as well as the family risk factors, and try to individually work with the schools. What we're finding is that You know, the most important thing about school is the education, but there's so many other valuable things about having kids in school, for socialization, for the camaraderie, for their learning of things just outside of the textbook. And so that's why the American Academy of Pediatrics has really said that the best place for kids is in school, with the major caveat that it depends on the density of spread in the community and what are the safety measures that are important for the community. So we're finding that we're going to have to work with our patients and our families on an individual basis. I know that we, in our practice, have crafted letters and worked with families to develop certain accommodations for their learning. And the schools have been pretty open to that. So you might reach out to them and see what kind of plans you can have adjusted for your particular situation. It's just really hard for us to make a blanket statement for everybody because some situations are extenuating, but that's how we've handled it at Texas Children's.
Okay, I think we better call it quits. And for those of you that still had questions on the chat box, we can answer those by email. But we don't want to keep anybody longer than necessary tonight. So I want to thank you on behalf of all of us in the Duncan Cancer Center. For more information, you can, or cancer care, you can call the numbers listed or the websites listed on the slide here. And any closing comments from anybody else? All
It was
right.
a pleasure to be here.
Thank you very much.
Thank you.
Thank you. Thanks, everybody.